Hello, everyone. My name is Tung. My friends call me Edward or Eddie. I studied at United States for 10 years and I graduated from UC Davis. I'm a current resident practicing at Yida Hospital, Taiwan. I'm your podcast host tonight. I'm also the podcast leader for the American Society of Plastic Surgeons, ASPS, International Resident Forum. This is a group dedicated to providing connection and exposure to plastic residents around the world. Some people may have heard or have joined international groups like ASAPS or ICOPLAST, but what we offer here is the association directly organized by the most influential and famous American Society of Plastic Surgery, the ASPS. This is a link, a platform, a stage, an opportunity for you to be directly connected and be socially connected and have your work exposure to the most renowned temple, the American Society of Plastic Surgery. And for our series that we have designed, we all know that plastic surgery training is one of the hardest, time consuming, and require massive time dedication. And since our target audience is you, the residents from global the world of plastic surgery, then my question is, how do different of us try to balance our lives between work and life in plastic surgery training? For example, when I see one of the seniors, how did he get through the plastic surgery training while being a father? Or how did the female plastic surgery residents survive through with 2 kids? Those are my questions, and I hope I'm not alone. I hope to find answers from my seniors to know, can I have a family while being a plastic surgery resident? Or am I dedicated to sacrifice my life for only work? Tonight, I have invited the first guest from Africa. His name is Toby. He is a current fellow training in Yida Hospital, Taiwan. The interesting thing about him is that in his country, his hospital, there is no facility for free flap reconstruction. He had to go through everything with local flaps, and he is here to learn free flaps. So I thought, with a person with such difficulties in the training facilities, how did he survive through his plastic surgery training? Hello, Toby.
Yeah, hello. Thank you very much for having me on the program.
Okay,
I'm
yeah.
really glad to join the group. Yeah, simply my name is Toby. I'm a plastic surgeon from Nigeria, and have my fellowship with the West African College of Surgeons
Oh, nice.
in plastic surgery. So yeah, that's a little bit about me.
Okay. Was it hard to become a plastic surgeon in Africa? Like, was it competitive?
Yeah, medicine is competitive everywhere in the world
Yeah,
because
okay.
as much as possible, I think it's one of the professions where, irrespective of where you get to find yourself or where you get to have your basic training, there's a barest minimum standard
Okay.
that is applied to everyone who gets the qualification to become a doctor. And it's not far fetched because at the end of the day, you expect that whoever gets qualified would be dealing with human lives.
Right.
So there must be a barest minimum standard, irrespective of how poor or how bad the educational value in that particular region
Right.
is. So yeah, it's pretty competitive. You go through rigorous um
Interviews. Do you have
yeah
to be the top of the
board.
class, or did you have to do a lot of research?
So for the educational system in Nigeria, the quite a number of things in the country is government controlled.
Oh,
Yeah, so if you want to go to a pretty good university, you have to go to one of the top-notch government um owned universities. So for me in particular, I finished from the University of Ibadan, and
okay.
I think it's a pretty popular university. Of course, the first in Nigeria. Yeah,
It's the best in Nigeria.
yeah, we said it first and the best, and yeah, we when
I,
when you
I I see that. I
when
see the
you
happiness in your smile.
Yeah, I don't mind me. It's something about that. And yeah, it's the first university in Nigeria, one of the first in the region. And for in particular for the medical college, for
Right.
medicine in particular, because of our association with, of course, we're part of the from a part of the British colonies. We're
Oh, okay.
colonized by the British. So when this university was instituted and medicine was started, ideally the final year when you finish from University of Ibadan, or rather before you finish from University of Ibadan, you have to go do a whole year in the King's College. That's University
Oh,
College London.
in London.
Yes,
Wow.
before you can get certified. So
Have you completed?
that's the standard. No, no, no. It's no longer done.
Oh, okay.
That was because that was in the tooting stage to make sure that you don't just churn out anybody
Oh,
as a
okay.
doctor because you want to meet up with requirements of the country.
Right,
So
right.
that's the early in the, I think that was the 1960s, 70s, and 80s, that period. So that was what was done. And the whole idea was to make sure the standard or the level of
Like the British standards, basically.
exactly. And the university, to be very fair, has maintained that standard. So back to answer the question proper. Um, when you finish, basically we call it secondary school, but it's more most people will call it high school.
High
So
school.
yeah, so after high school,
Right.
it's a combination of two major um examination. So one of the common one is what we call the West African Educational Council. So it's not just a local exam for Nigeria. Most of the West African countries are also signatory or participants of that body. So
Right.
you get to do quite a number of subjects, at least about 9, 10, and you have to really ace those subjects.
Oh,
So
wow.
in combination, that's in combination with another body, which is more like the Joint Admission Matriculation Board. You have to also do that, and yeah, they get to filter a lot of people. So it's not just your interest, you have to also get very good scores, and most of those institutions would also set up very high benchmarks for people who would be admitted
Oh, wow.
to study medicine. So that's the beginning of the journey. So that's,
Okay.
and of course that's just the first stage. It's, but
So-
we all understand that
So how was your family's viewpoint in this? Like, are they financially supporting you, and is it expensive to go through with the?
for medical school.
Yeah.
Okay, yeah. So for medical school, because it's largely, like I said, it's largely government controlled. There now at the moment there are more private universities that also offer medicine as a course.
Okay.
Yeah, but to be very, very sincere and honest, when I was doing, when I was applying, I trust me, I think there were probably just one or two private universities at that time.
Okay.
And for the life of me, I would not have gone there.
Why?
I don't know, when something is starting out new and
Oh,
you
because the
have the
system is not
yeah,
mature yet.
yeah, and you
Okay.
have a prestigious place like University of Ibadan with the
Mm,
teaching hospital, which is University College Hospital Ibadan, mirrored after the University College Hospital London. You want to
right.
have people who have finished. You've seen how they go through things, how they basically take care of people, because yeah, I don't like to. Yeah, there are glory days
Right.
for the institution, because most people, if you just pick up and do a bit of a search, the university, well, hospital, let me put it that way, because we're talking about the university itself and the hospital that is attached to it.
Right.
The hospital was so good that, in fact, the at least from what we know and the stories that most of
Right.
my teachers told me, um, the Saudi family, the royal family,
Okay.
they actually came to University College Hospital, or rather, not they came, they normally come for annual medical checkups.
Wow.
That's how good it was. But of course, like they say, most good things come to an end. But no, it hasn't come to an end. I think it's still, but there's some law of diminish in supply in yeah, I think so. It's utility, if economics, if I remember, there's usually a diminishing. in things. So I think that also is a little bit of the problem, but it's still one of the top notch place. If I have anybody who wants to go to med school, I'll still advise you as
Okay.
long as it's in Nigeria, University of Ibadan.
So that leads to our next career questions, like what inspired you to become a plastic surgeon, especially, in, I think you said, in your country, which is
Nigeria?
Nigeria, that has like no microsurgery free flats
Okay.
facilities to help you.
For interest, I think most times as as days go by and as time passes, um one begins to get clarity into what you want to do. And why do I say so? Yeah, of course, the interest to practice medicine was there. Went through med school, finished, and got the degree. And while doing internship, most times a
Right.
lot of people, either you have an idea of what you want to do,
Right.
or you don't before internship. I think for me, it was mainly during my intern year that I knew first and foremost it had to be surgery.
What sparked you?
For surgery, I think surgery is just more of the, it has to do not just with what you synthesize in terms of information, because medical practice, you need to be able to synthesize a lot of information.
Right.
So first, someone walks up to you, tells you a whole list of symptoms. You try to elicit signs. You want to arrive at a diagnosis. The next thing is, what do you do with that? So if you can't synthesize information so much, then yeah, one might have a lot of problem. So, but for that's the basic for medicine.
Right.
So
Right.
for surgeons, you synthesize that information, and you have to also do something with it. So,
Right.
and that the thing I'm trying to say is, you're not just trying to, okay, yeah, I've gotten the diagnosis. I know what maybe categorize it into a syndrome or anything,
Uh-huh.
and looking for maybe some medications or things to help me out and wait and see how the drugs would work. For surgery, it's you have to get your hands in and do something.
Right.
Yeah, of course, it's not every time, because the common saying, a good surgeon knows how to cut.
Okay.
A
Right.
better surgeon knows when to cut,
Okay.
and the best surgeon knows when not to cut. So it's not just
Wow.
about going in and doing surgeries, but once there is an indication for surgery and you know you have to intervene, it's no longer just those informations you have synthesized. You also need the information you synthesize to put into practice. So a lot of hand coordination, you have to put all of that into it. So I think for me, that was just being fascinated more with surgery and seeing how much one can put into pieces damaged tissue, and yeah, may not come out perfect the way it was originally created, because of course we're not God. We can't
Right.
recreate things, but you can fairly put it back together and restore some function and also some form of aesthetics. So I think that's why function and form came into place, and naturally kind of gravitated into plastic, because which other aspect of surgery would consider not just the function but trying to restore form back to its original structure? I think it's plastic surgery. And
Right.
going through the plastic surgery department
Mm-hmm.
during my internship also kind of just solidified it, and since then it was just more like, this is what I'm going to do.
Wow. So since you said you wanted, what inspired you to become a plastic surgeon, then my next question is, have you thought about, or have you already decided, like, which part of a plastic surgeon that you want to specialize in, or
Yeah,
an aesthetic, or
yeah. Okay, so while doing residency, maybe later on, should I go now? Maybe later on, I can break down how we run our residency program.
Right.
But right at the middle of my residency program, I think another decision was made. So internship, I knew it was surgery. I knew it was going to be plastic surgery. So
Right. Yeah, explain that
all my
well. Right.
applications were geared towards that. And right at the middle of my residency training, I also knew that for plastic surgery, I wanted to do things with hand.
Hand.
Yeah, so that's the thing. I think
Wow.
right from the middle of my residency program, I already knew that I would want to cone down towards hand. And of course, if you're going to be a hand surgeon, it's near impossible for you not to do microsurgery. In
Right.
fact, right now, being a plastic surgeon without the super specialization of some form of microsurgery might be really, really difficult or near impossible. Yeah, we know microsurgery now is even further breaking down into the super micro and now the new nano. Yeah, there's a
Yeah.
nano
Wow.
what yeah, I think it's nano surgery that it's being called because I think that's spearheaded by Professor Koshima. So it's crazy. I think the end is I don't know where it's going to lead to, but it's a lot.
Wow. And you know this is a difficult specialty.
Of course, I know that.
Like a lot of like surgical operations, like especially from trauma, is just long and requires a lot of physical stamina and concentration. Why not something lucrative?
Earlier in the discussion, mentioned a lot of things are government controlled in the country because I think our system of government is set to be more of a mixed economy. But the truth is, it's more socialist than anything. So more of a mixed economy. So
Okay.
yeah, you allow a bit of capitalism, but the truth is there's so much of government control. So if you want to go to any of the good universities and things like it's um government. Yeah.
Controlled.
Yeah. So of recent, yeah, there are more private institutions and things. So imagine a country where you have that amount of government influence. For things to function, it's government controlled. So the big institutions, the big tertiary hospitals are all associated or
With the
tied
government.
to the government.
So it will be harder to have a private owned practice.
No, there are. That's why I said it's a mixed economy. So they allow for some of those things. So basically, when you think about the teaching hospitals and things, you have to more or less patronize or go to the government owned facilities, which we know the policies and everything, the functionality would largely depend on the government. So it depends on how responsible the government at that time would be.
Right.
So you can have successes in previous government, you come in, you have a new set of government who don't place it as priority, then you get what they give you. But on the other hand, there are also private, like I said, there are some institutions that started
Mm-hmm.
having medical schools, and there are also there are also private hospitals big enough that can do a lot of things.
Right.
Yeah, so um, I'm trying to give two different perspectives of things. So one is government controlled, then there's also the private hospitals, and you can understand what would happen. So for government hospitals, relatively, they are cheaper than the private,
Yeah, I think that's
than the
everywhere.
private hospital. Yeah, so that's one aspect of it. Then secondly, Nigeria is not just as simple as people want to put it. A lot of things, there's a northern part, there's a southern part. And there are different states within there are 36 states. Let me not say about, there are 36 states. So you have some states that are, of course, richer than others.
Right.
So where you have private hospitals in those kind of places, of course they can do so much because and they have the patient base who can afford that kind of practice. So why I brought this perspective into it is I work the teaching hospital where I belong, where I work, and I'm currently employed, is in the northern part
Right.
of the country, and the state is not so, yeah. So Kaduna, that's in Kaduna State, but it's in a town called Zaria. So that's Ahmadu Bello University Teaching Hospital. So um yeah. So basically, it's not a rich state per
Okay.
se. Have quite a number of poor people who would definitely patronize the hospital. But somewhere down in Abuja and especially Lagos, where the commercial capital, former state capital, there are some private hospitals and people who can offer complex reconstructive surgery, because I have two of my teachers who, oh, sorry, three of them. I think two of them even came to Taiwan,
Oh, wow.
yeah, to learn microsurgery. And they're back in the country, or they've been back in the country for years,
Right.
and they do microsurgery. But of course, it's not on a large scale. It's for those who can really afford, or because the way the insurance scheme is, um quite a number of patients would have to pay from their pockets, and once health payment is out of pocket, it's pretty expensive. So very few people will be able to afford it. So it's not as though in the whole of the country there's no microsurgery being done. So there is, but it's on a very, very small scale. And maybe to even put it into perspective, um, we have a population of about 200, and as at the last census we keep on projecting that
Right.
there's a 3% growth every year, but unofficial projections were close to about 250 million and above in the country at the moment. And we have just about, I'm not sure of the total number, but I don't think we're up to 200 plastic surgeons in the whole country. And trust me, because plastic surgery is very wide, not everybody would want to go into microsurgery
Right.
because of what you mentioned. One, it's time consuming. You can do a single case for about 6 to 10 hours or even
Right.
more. Um, Financial aspects. If you work in the teaching hospitals, you're not getting any more benefits because you spend 10 to 12 hours doing a particular case than someone who does a 30 minutes, 1 hour case. So
Right.
that's where the perspective of lucrative comes into play. But we would naturally fall into our interest groups, and I think that's just it. So we all had what made us come into plastic surgery. Some would find the aesthetic aspect of plastic more appealing to them,
Right.
and it might be more rewarding in terms of financial benefit, but others would find other things. And sometimes when you see complex defects that one would have to use the microsurgery option for reconstruction, then you need quite a number of people to go in there. And I think quite a number of Nigerians are getting more interested in
Into
microsurgery.
microsurgery.
Yes, and hopefully we should be able to get there and catch up with the rest of the world and prefer solutions to citizens who would need the option of micro. So I don't know. I think maybe that picture might have helped a
Yes.
bit. Yeah.
Yes. It's very clear. Very clear. Can you tell us a bit? I'm very curious about how you guys do a lot of surgical operations with local flaps. Could you tell us a bit about the cases, like for example, the trapezius flap cases that you wish you could have done it with the microsurgery, and how you overcome the challenges of without anyone teaching you with the defect so large? How did you overcome it?
Okay. So basically, one thing surgery, or let me start with the foundation. One thing medicine gives you is the ability to try to sometimes think outside the box.
Right.
And as a surgeon, you have to also do that. You have to be able to think out of the box. And as a plastic surgeon, I think you have to think way outside the box also, because even some of the principles for Millards, you get to see that you have a plan A, then you should also have a plan B.
Right.
So plastic surgery, you can't, as much as you do the preoperative rounds and preoperative planning, your preoperative planning should not just be one way. You need to have, okay, this is my A game. If I go in and everything falls into the part, I execute this with strict perfection. However, you should have other plans, have a plan B and a plan C, and sometimes even a plan D, and at least go through them. So that's what plastic surgery kind of affords you to do. And coming to my institution, we're about maybe a bit of a background also. For Zaria, the teaching hospital there, um, we cater for quite a number of people. So in the States alone, based on also some estimated population as at the last population count, should be about 8 to probably 10 million people. So um, we are just four plastic surgeons in that place. And the way the institution is, because it's also another pretty old institution, I think over 44 years old, we also get referrals from neighboring northwestern and even northeastern
Wow.
states and not central states. So imagine that volume of patients coming with all forms of defects or things that would need a plastic surgeon to take care of, from aesthetics down to trauma to malignancies, even fellow colleagues calling you in following maybe a tumor extirpation, and you need to reconstruct or obliterate that, give them some form of cover. There's no how. You have to try as much as possible to think out of the box. Yes, we know, based on the reconstructive ladder, elevator, whatever you want to call it, or the toolbox, which is
Right.
basically the best thing
The
available.
foundations.
Yeah, so but we know the toolbox is the best thing. You give the right option. And we know some of those defects, what you need is a free flap, because you can look for a donor site that wouldn't have so much morbidity, and you can get the required amount of tissue that is needed. So this tissue can be bone, muscle, whatever it is,
Right.
and you then move it to reconstruct the area that needs to be reconstructed. But when we don't have that available, you have to think of something. So I think some of the cases, yeah, the trapezius flap is not so much, it's not that common.
Mm-hmm.
Yeah, it's not so common in that sense of it. It's used a lot for brachial plexus injuries. That's the truth.
Right.
So most people where you see have experience with the trapezius flap, it's used for brachial plexus injuries, and most times it's also done as a free flap.
Right.
So yeah, but in this case, it was a huge
It was a huge defect.
Yeah, it was a huge defect, occipital region, squamous cell, and he had the tumor taken off for over 6 months and was walking with a huge wound. Margins were free, and
Wow.
part of the occipital bone was also gone from the defect. So it was just dura. And
Wow.
of course, you need to cover that, because you don't want someone walking around that way. And there was no indication not to resurface it, because the margins were free, and he had already gone through the gamut of MDT, had his radiation therapy. So we started thinking, you don't want to go to the least of the reconstructive ladder and say, oh yeah, we just wait for granulation tissue to cover and slap a skin graft over that. It's not going to be ideal.
Yeah.
You need
The defect was too low.
yeah, you need supple and durable tissue to be
Right.
able to cover that. And yeah, kept on looking. Yeah, saw how the trapezius can be moved as a pedicle flap. So the thing is, the good thing is I don't work in isolation. So, and we're four in the department. I have two very senior. The three of them are senior. I'm actually the youngest in the department. So, I and the next person, we kept on looking through what can we do.
Right. So I
Yep.
just want to drop in like a quick note here. The reason why I brought up this story is because it really shocked me. When I saw the defect of the trapezius flap, and Toby told me that he had never done it before. And so I asked him, like, if you had never done it before, how did you operated it? And he told me he just studied it through textbook and just try to do it, try to operate it. And like the department head in the Ida hospital right now said Toby is one of the best microsurgery fellow that he has seen so far. So I think that just shocked me because a person who do a lot of practices, try to self-learn, self-teach through textbook can come so far and be recognized internationally. I'm just curious, like, what was your mindset behind it? Like, were you scared of complications, or like what drive you for this thing to do that you've never tried before?
Yeah, I think you're just blowing too much music on me. It's not that great. Okay, so yeah, like I said, the good thing is you have people you work with. And when problems like that come up, it's almost like having an MDT, the whole idea of an MDT. But in this case, you're doing more discussions, more of a peer review with each other. So the patient comes in, you're lost initially when you see the defect, and the first thing that comes to your mind is, oh, micro. But that's
But
not
that's not an
available.
option.
Yeah, that's the best thing the person can get, and that's not on the table at the moment. Do you want him to spend more money and maybe look for those who can do it somewhere else, and he doesn't have that money? Then you get to review with your peers. So that's why I said I'm glad that I have others in the unit, and we started looking through. Okay, when we have this kind of defect, what are the possible local flaps we could move
Right.
around that would give us meaningful reach and meaningful cover, and how do we get to do that? And we stumbled on some journals talking about the trapezius, how it can also be moved to cover some defects in the posterior neck, and also getting all the way to the occipital region.
Right.
And yeah, looked at that, read about it. The most important thing when reading
Did you tell the
journals,
patient like that was like one of the first case
yeah, most times you have to,
in the
when
country?
you get consent, you have to be as honest as possible. If you're
Wow.
not comfortable and or confident in yourself for a surgery, then the best thing is don't go ahead.
Wow.
But if you have some form of confidence and you're comfortable, you don't have to. That's the good thing with plastic surgery. Once you keep to the principles, and you have your first option, the second option might not be what you've done before, but there are things that maybe you've looked through the journals, you've had some maybe practice on dummies, or
Right.
yeah, and you've seen, okay, yeah, this can move, this can go ahead. And so the trapezius flap, moving it as a pedicle flap is not so different from every other form of pedicle flap that one moves. Maybe you're talking of the latissimus dorsi. It's not too different from that.
Right.
So the
Right.
most important thing is stick to the principles. You know where the blood supply comes from. You
Mm-hmm.
also want to, as much as possible, where the perforators, if you're taking along with the skin paddle, you also want to know the perforators that would supply that skin paddle, because you don't want to have necrosis. So you have to be gentle around those areas. Then, of course, planning in reverse also helps, because you want to know how much of reach the flap can um,
Right.
how you can move the flap and the
Right.
distance that can be covered with it. So most times, once those principles are followed, yeah, you're likely to have good success with it. And that was what we did. I and the other person, yeah, Dr. Kabir, that's his name. So that's what we did. And we did the first one, came out well.
Okay.
And
Well,
ironically, someone else came up with very similar, identical defects,
wow.
same region. And yeah, we
And
did
you
this.
applied again.
Yeah, the same thing. So well, you don't change a winning formula. So when one works, yeah,
Wow.
you can do it again, and there was more confidence this time. Of course, you have to be comfortable before you go ahead. So yeah,
I think
it,
that's the spirit for a plastic
yeah,
surgeon. You dare to try, and once you know the winning formula,
yeah,
you want to
yeah. Because even
do it again.
even for microsurgery, as much as there are different donor sites and all, you still find most microsurgeons would have their go-to flaps. So for some people, it's ALT. If they give you their list of flaps they've done, you might see that all they've done for a long time is a particular flap. So it happens that way. So once you have something that works, and of course, with more practice, you get better at doing things. So if
Right. That's definitely inspiring to the global residents around the world. Like for sure, like that you show them how you overcome your difficulties. You know the best option is free flats, but you overcome it through textbook, through journals. I think a lot of us around the world, we are just trying to picture what the elephant looks like in the dark. And we're unsure if we can do or if what we are doing is right, and you just show us the perfect example. I finally I do want to ask you like what's your future direction like, so you come to a foreign country to do your fellowship program, like do you plan to go back to your country and try to help out the try to grow the microsurgery team, or you will go on to even more countries for fellowship programs?
um so basically the easiest way to answer is of course when I'm done,
Right.
you want to the whole idea of the fellowship or even coming to learn microsurgery is to see how one can increase the number of micro surgeons in the country. It's like I mentioned earlier, it's not as though we don't have a handful of people, but it's that number is never going to be enough. So it's to see how one can also improve. And for my region, the region where I
Right.
practice, at
The
least
northern
have,
part.
yes, have one or two people. So that's the whole idea. My mindset is to go back and
Just one or two.
yeah, no. That's the start.
Okay.
The journey of 1,000 miles starts with
Wow.
a step. So
But like you
for
said,
for
so many
now,
people need it.
yeah, so many people need it. So when I go back, at least I should be able to gather a team together and start something. And of course, you light a small fire and keep putting fuel, and the whole building is is set ablaze. So that's the whole idea that I
Right.
want to do. At least get the knowledge and be able to set up something and see how one can provide patients with what they actually need, because as good as pedicle flaps are,
Right.
one has to also think of the morbidity and yeah, majorly morbidity to the donor sites. That can be a huge problem, especially if you can't close the donor site. Of course, we always attempt to close the donor site, but
Right.
the problem with always attempting to close the donor site is you might not get adequate tissue to
Right.
cover or to move to what you want to cover, but somehow you have to be able to work things out. So you can do that in combination with another rotational flap. So you have to really think wide and see what the possible options are.
Do you consider other countries for training for your fellowship
Uh,
program?
Definitely.
Right.
Definitely. The whole idea of training, it doesn't have to be microsurgery because I mentioned to you earlier, my interest still remains hand surgery.
Right.
But because of the population, the amount of people, and I told you we're just four plastic surgeons in my institution and in that region, um, you don't have that liberty to say, all I want to do is hand surgery. I know in some places people don't even just do hand, might tell you all I'm doing is the carpal bone. So just within the carpal
Wow.
region of the hand, that's all they do. Some will tell you all I'm doing is just nerve reconstruction. We don't have that liberty. We don't even have the right amount of or the number of doctors to patient ratio.
You had to do everything.
Yeah, so basically the WHO recommendation is I think it was 1 to 600, a doctor to 600. Later there was a consensus of 1 to 1,000 is okay. I don't think we have that number. Probably we're doing 1 to 6,000 or
The
something. So um so
country really
so
needs
that's
you.
so yeah, so that's even for doctors, those who doctors, let alone plastic surgeons. Remember, I think I said the last count, we're not up to 200 qualified plastic surgeons. Yeah, the good thing is there are quite a number of people in training at different stages of their training.
Right.
So, but for now, I don't have that liberty. I can only keep it as an interest and do as many hand injuries or hand anomalies or problems that come along, but
Mm.
I'm not going to see a trauma case and say, that's not me, or a head and neck problem, or the cardiothoracic surgeons call you, there's a mediastinal defect and they need you to move something around. And I would say, no, I'm not going to move your latissimus dorsi to cover the mediastinal. It's not possible. So you still have to do every general case. But of course, if I have the opportunity to go do other fellowship, maybe in hand and all, why not? I'll do that because
Right.
you never stop learning.
Right.
You only stop learning when this is all over.
So I want to give you the final questions, and this is the message to the global residents around the world as well. Like, if you could repeat your residency again, what would you advise yourself? And or what would you advise residents around the globe right now? Like what they could have done, what you could have tell yourself to improve, to not go to do the right thing.
Okay. Thank God this is a hypothetical question
Right.
because the first answer I would give is never. I'm not going to do it again. Yeah, because it's all mixed. You have days you just wonder, for the life of me, why did I get myself into this? When you look at the work, but the good thing with it is couple of advice. I got a very good one from a very senior colleague. He's
Right.
also a plastic surgeon. Even
Okay.
at that time, I hadn't even I was still doing the general posting because we do the way the colleges are, the first 3.5 years or thereabout, you're doing more of general surgery posting and
Right.
some subspecialty. Then you take an exam.
Oh,
Yeah, you take a
you take
board.
an exam
Yeah, you
after
take an
general
exam.
surgery.
Yeah, after the 3.5
Mm.
years, you take an exam. Then after that exam, um, you then probably move into a super specialty where it now depends. So plastic surgery, you can do another 3.5, 4 years. So depending on what you do. So I was still doing the general. I had not even gotten into plastic, although I knew I was going to do plastic. It was already cast in stone that
Right.
that was what I was going to do. And some days I would look and it was difficult. That's just the truth. Because at that point in time, the impact of residency was already telling on the country because quite a number of doctors were either doing something else or would rather go do the residency out of the country. So there was a lot of shortage. Most times I'm on call 5, 6, sometimes the whole week I'm on call.
Wow.
Yeah, so it was that difficult. And the good advice he gave me was, don't worry, to come to an end. It
Okay.
sounded very simple, but it made a lot of sense because every morning, immediately the sun comes out, I would say, God, thank you. This is another day. And yeah, now I can say, yes, it did come to an end and I didn't die
Wow.
because there are nights you're not even asleep.
Yeah,
You're
like so
in
sleep
between.
deprived. I'm
Yeah,
so
there might
tired.
be an
Feel,
emergency. You have
yeah.
patients on the ward who are pretty bad. You have to do a couple of things. You also have to run the emergencies because when
Right.
emergencies come with your specialty, they're going to call you after probably stabilizing the patient. So you're in two, three, four places at once. And you also have academic activities because we have seminars, we have different things that the department would organize. And sometimes you have presentations to make. So in between all this,
Right.
it's very easy to throw in the towel and say, why am I doing this? It doesn't make any sense. But I think that advice, till tomorrow, I remember it very well. I think it kept me going. It'll come to an end. Tomorrow would come.
Wow.
And
Simple
that,
and
and
strong.
yeah, it didn't, when he said it, it didn't sound like this is what I need
But
or
it's
what
what you
I
believe in
help.
your head.
Yes, because at that point in time, what you want is someone to just tell you, oh, go home for like 2 days, or that's all you want to hear. But he wasn't even in the unit. He was a very senior person in plastic surgery and just said, don't worry, give it time. It will come to an end. Just learn what you're meant to learn. Focus on what you're meant to focus on. And I think that was it. So um to answer it, yeah, I'll never do it again. That's one. Secondly, yeah, it's going to come to an end. You definitely know why you got yourself into it. I think that was my own psychology, more like nobody forced me
Okay.
to practice medicine. Nobody forced me because the entrance into all this, both medical school, residency, the exams you take, and all, nobody forced you to do all that. You decided for whatsoever reason. You went, you had an examination, there were competitions or people who wanted to come in and probably you were selected. So
And
that
yeah.
should be enough motivation to help you to achieve what you want to achieve. So that's also on my own end what I used to like tell myself, yeah, if I wasn't forced. So if I were to be forced, trust me, I would have handed in the towel and have walked away. But because it was my decision, so let me see the end of it. And if after seeing the end of it I don't like it, then no problem. I think it's good.
That was definitely the best answer. I wasn't expecting that answer, but I think it's simple and strong. It's about remember why you want to to be a plastic surgeon, and also believing that all this will be better tomorrow.
Yeah.
Yes. So that gives us a conclusion. Thank you very much, Toby. I thank you very much. I think that was a very, very strong and inspiring story, personal story. I hope that this story can inspire global residents, global plastic surgery residents around the world to know that you are not alone, the difficulties. And I do hope that for people who are interested in telling your story or dropping your CV to showcase yourself onto the ASPS IRF podcast, then please drop your CV and story to the provided email address aspsirfpodcastam@gmail.com. aspsirfpodcastteam@gmail.com. If you are interested in showing your story, your CV, and be connected to the most renowned and famous plastic surgery group, ASPS, please send us a message and we will set up the stage for you. Thank you very much. Good night.
We hope you enjoyed this episode of the Enhance Your Practice podcast series brought to you by ASPS University. You can listen to our other episodes on any of the podcast platforms where they are currently available, or you can download recordings directly from ASPS EdNet. New seasons and episodes coming soon on practice management. Please contact ASPS Education with your feedback and suggestions for future podcast topics. Thank you for tuning in.